So here's our bundles. We have resuscitation bundle and our management bundle. So all you ED nurses, your 6-hour bundle is a resuscitation bundle. And the big Surviving Sepsis Campaign article was just published showing that in terms of the overall rate of CVP greater than 8 within 6 hours, nationally it was 34%. So we have a long way to go for that early diagnosis. Really 34% nationally with 15,000 patients in their database. Only 34% were accurately diagnosed and treated within those 6 hours. So that's only 34% of the total population of severe sepsis that actually got that bundle element met. So let's agree, we have lactate, blood cultures prior to antibiotics, early source control. You notice source control is not a 24-hour bundle element, it's a 6-hour bundle element. Broad-spectrum antibiotics, again, 2 hours to diagnose, 1 hour to infuse. For hypertension or lactic acid over 4, we want to give that initial 20 mils per kilo, about 1.5 liters. Certainly most ERs are now giving up to 8 liters, but certainly initially it's that 1.5 liters. And then vasopressors not responding to fluid resusc. Remember, treat these patients like trauma or burns. We want to give the fluid resuscitation first before the pressors. And then for persistent hypotension, despite fluid resusc, that's where we're going to put in that CVP and get it 8 to 12 for non-intubated and 12 to 15 for intubated, and watch that low urine output. Grab those SCVO2s. If you don't have that preset catheter, just do serial SCVO2s and utilize blood products to keep those crits up. For the management bundle, we want to look at low-dose steroids for septic shock. So if your patient's on pressors and you cannot get them off pressors, they failed a reduction in pressor dosing, then we can use those low-dose steroids. Surgicogen alpha activated, screening, glycemic control, less than 150, although my facility is up to 180 on that now after the NICE study. And then our low tidal volume ventilation, the gold standard for lung protective strategies. In terms of clinical definition, it's certainly more difficult without that single tester marker. And I recently started utilizing procalcitonin about a year ago. But really, for the first 5 years that I was doing the sepsis initiative, we had no lab tests. And I've been reading about procalcitonin since early on, hundreds and hundreds of articles, and I was so excited when I finally got PCT because I finally had a lab test. Everyone thinks that lactate is the lab test for sepsis. Lactate has nothing to do with infection. All it tells you is that you're in shock. In terms of I work in a neurotrauma ICU. In terms of acute intracerebral bleed, we can grab a CAT scan. For malignancies, grid look to the pathology. For our MIs, we just grab those CPKs and troponins. And for trauma, of course, if we're looking for fracture, we just look for radiology. And so with sepsis, there wasn't that actual lab test. There are options available, and I have been utilizing procalcitonin for about a year. What is procalcitonin? It's a prohormone of the hormone calcitonin. It's produced by several cells in your body and many organs in response to the pro-inflammatory stimuli, in particular bacterial products. The normal is less than 0.03, and it's usually not elevated by viral infections, colonization, and autoimmune diseases, and this is huge. The procalcitonin increases within 2 to 12 hours post-bacterial infection. So if in the ED your first PCT is low or negative, know that second PCT about 6 hours later would be a good idea because it does not increase for 2 to 12 hours. Think of it like you do our MIs where we have our serial cardiac enzymes. The PCT does have a half-life of 12 to 24 hours. And I will tell you, when you first put out a PCT at your facility, it's imperative that these details are educated to your entire staff, physicians as well as your nursing staff, because the devil is in the details. And if the details are not properly described to your staff, there can be some misinformation and miscommunication and misuse of procalcitonin. You can trend it over a 6-day period. So I really want to emphasize the importance of the details of procalcitonin early on when you're putting out PCT to your staff. There are some caveats. Multiple traumas, major surgery, severe burns, or neonates can have elevated PCTs, but return to the baseline can be rapid. Remember, the half-life is only 12 to 24 hours. And I think this next bullet point is very exciting, that PCT times 2, 6 hours apart, has a 95% negative predictive value. So that's huge, just like those cardiac enzymes. In terms of pancreatic diagnostic assistance, it can certainly help to determine whether it's infective versus sterile. And plasma levels rapidly fall as the inflammatory activity regresses. So I actually have seen a PCT level of 100 go down to less than 5 within 24 hours of a patient that started out with multi-organ failure, but due to our excellent care here at Mission, was able to get that patient turned around very, very quickly. And those PCT levels did reflect that. I think it's important that with relevant bacterial infection, the PCT is produced and released into the circulation from the entire body. C-reactive protein is a response from interleukin-6 that goes to and is made in the liver and released into the bloodstream, whereas procalcitonin, with sepsis, is actually made by multiple organs and tissues throughout your body. I think that's really important to know. This is Bone and colleagues. This bone classification just shows that you can kind of look to severity of illness and your PCT levels. And this kind of depicts that with no sepsis, these 22 patients had very low levels. With sepsis, with those 96 patients, had moderate levels, and then it continued to increase in terms of severity of illness. And this slide shows the same thing. This was Kirsten Springer and colleagues, and he also showed that the higher the level of PCT, the severity of illness did continue to increase. In terms of comparison with procalcitonin, this, I think, is important to realize that the specificity and sensitivity with PCT is higher than with C-reactive protein. Here at Mission Hospital, how I utilize PCT as part of my comprehensive Surviving Sepsis Campaign initiative, I actually looked at it quite thoroughly. I looked at the first 109 patients. I actually did 20 patients under the radar before I released procalcitonin. We did a study, and I'll talk about that after if you want more details on that. But I did a quick check of 109 patients, and for me, this is only my experience, I had 77 that correlated with not only the diagnosis but also blood cultures. So the negative PCTs had negative blood cultures, positive PCTs had positive cultures that related with diagnosis. So I had to be on the protocol, have an actual intensivist diagnose the patient, and have a discharge diagnosis. 35 correlated with diagnosis, but not necessarily blood cultures. We know as clinicians that many of our sepsis patients do not have positive blood cultures. So I was interested to find out in terms of bacteremia and PCT. 35 of those 109 actually were diagnosed with an infection and sepsis, put on our protocol, and discharged with a diagnosis of sepsis, but had negative blood cultures. Those patients also had either blood cultures from the sputum, blood cultures from the urine, they were C. diff colitis, they were perforated bowel with peritonitis, but they didn't have positive blood cultures. But those patients did have positive procalcitonin. So let's clarify. They have positive procalcitonins, positive respiratory cultures, urine cultures, C. diff colitis, perforated bowels, and there were other cases in there. But those were the sepsis patients with positive other cultures and a positive procalcitonin, but negative cultures. Then I had 7 that were all over the place. 4 of them had high procalcitonins, but were end-stage liver disease and not septic. 3 were cancer patients with an assumed neutropenic sepsis, but didn't have positive cultures. So that's kind of my little personal experience I just wanted to share with you. And I did relate that to my physician and nursing staff. We also wanted to make sure that you realize that it is endorsed here by the IHI, the IDSA, and the Society of Critical Care Medicine as one of the variables for diagnostic criteria to help with the diagnosis of sepsis. So I wanted to do a quick case review for you. This is a patient I had about a year ago. He's a 30-year-old male. He was a fourth-year medical student from the East Coast during clinical rotation at a local medical school. And I just want a quick disclaimer. I'm not making recommendations for care here. I'm only sharing my personal experience. This patient, in terms of EMS, he was brought to the ED via ambulance after a grand mal seizure in the doctor's office. He was pale, ill-looking. He had a fever of 102.4. He was tachycardic. He had a high respiratory rate, and his blood pressure was 80. He had shortness of breath, a heavy chest, and general malaise, and he had a 2-week history of a productive cough. He was on Advair and Accutane, and he had no significant medical history. He had decreased breath sounds on that left lower lobe. His SATs were 80% on 100%. He, again, in the ER was tachycardic, tachypnic, and he had hypotension. In terms of labs and radiographs, he did have a lactate point-of-care testing, BMP, CBC, PCT. We drew blood cultures and did a chest X-ray. While in the ED, he had emesis ×3 with an associated decreased level of consciousness and another possible seizure. They did call a code. He looked that bad that they actually called a code in the ER. He had decreased respirations, and he had hypotension. So off to CAT scan he went because they were trying to find out, again, what those seizures were all about. The lab results showed during that time that his PCT was 26. His white cells were 18 with 25% bandemia. His bicar was down to 19, so we know he needed fluid. His head CT was negative, and his CT of the chest did show a left lower lobe infiltrate. This is his chest X-ray, and there is that left lung infiltrate. And what that looked like on the CAT scan, there's his lung CT. It was done with that contrast, and you can see that big pus pocket, that left lower lobe infiltrate. It's very apparent, of course. So there's his big pus pocket. Those are those white cells that have gone, done their job, and died.